Welcome everybody. Bonjour à tous. I'm Dr. Timothée Olivier, medical oncologist practicing in Geneva University Hospital. This is the first video of a new channel called Primum non nocere. First, do no harm in English, d'abord ne pas nuire en français. And in this channel I will try to put videos about critical thinking, how to appraise medical evidence, shared decision making, all related to what I think is the core of what we are doing, is trying to make and discuss the best decision with and our patients. Mostly related to oncology, I will try to put videos in French, but this talk was asked by colleagues that are following me on social media, and this is about how I read clinical papers, a recent talk I gave in Switzerland. So let's get started with how I read clinical papers. I have no conflict of interest. And first, I think the context is very important. This study was done with Vinay Prasad and his team, and we looked at more than a decade of FDA-approved drugs in the advanced or metastatic setting. What you can see immediately on the left is in 2009, there were less than 10 approved drugs. In 2020, it was almost 60 drugs. So you can see that there is an increasing number of approved agents, and of course, as you know, an increasing number of publications. To add a layer of complexity, as you know, in the same paper we describe all the targets, the biological targets, and you can see that there are many targets. We won't go through them, but this is adding another layer of complexity. The Keynote 048 study, head and neck cancer, 14 primary hypotheses. We have to go through this kind of complex statistical analysis, and this is more and more coming into trials, and this is another layer of complexity. And last but not the least, and this was a very nice paper published by Del Peggio and colleague, and what you can see over time is that nowadays randomized clinical trials are almost entirely financed by the industry, and this is of course creating an important role of financial incentives in trials. So with all this, you can immediately realize that reading papers is really a hard task, and this is illustrated by Salvador Dali trying to read a newspaper here in this famous picture. So the second question, why reading is so important? I think this is really the core of what we are doing daily as healthcare providers. Shared decision making, real shared decision making. And this has to integrate many things. Clinical expertise, of course, values and preferences. I think this is really a core pillar of shared decision making, and we should not forget it. But also the level of evidence. And the level of evidence is really what we will be talking about today. And actually, this is the definition that David Seckert gave about evidence-based medicine, which is the integration of best research evidence with clinical expertise and patient values. So my talk will be divided in which papers to read, how I read, so what to look at in papers, and how to integrate it will be my concluding slide. So which papers, in a short answer, registration trials. I mean, paper that could modify my practice, and are often registration trials. What is a registration trial? It's a trial seeking to get marketing authorization for a drug, what we call approval. So you will see this kind of papers in the New England Journal of Medicine, of course, and other big journals, but sometimes it's also in journals that you may not have think of. So I think a good way to follow that is to follow, in the field that you are interested, the expert maybe on social media or other ways. But also I think you have to read, or at least know, the papers that are the talk of the town. What I mean by that, I will explain you. So let's take an example with the Atalant-1 trial. So the Atalant-1 trial, we won't go into the weeds of this trial. We would have things to say, but this is not the topic of today. But it's a cancer vaccine trial. It's a French startup. You will see why I precise this on the next slide. and it was comparing this cancer vaccine against chemotherapy in HLA-A2 positive patients. The timeline is the following: 11 September publication, French TV, you understand why now, 12 September 23, and you can see a 41% reduction in the risk of death. This is the headline, and you can see on the expression of the journalist that the journalist is very, very impressed by the results. And what will really happen is that the patient would start queuing or phoning or calling the next day or even the same day. And you know that this is really happening with the headlines we can have in oncology, but also in other fields of medicine. Now, how I read, and these are some, I won't cover everything. I won't be able to cover single-arm trials. I won't be able to cover sample size today, but we will see many of these topics. But even before the control arm, I think the control arm is very, very important. Even before the control arm, I think you should really check the setting. The setting is inclusion-exclusion criteria, and the question behind that is how closely does this match my practice? Let's give an example. The LUNAR trial, it was very recently published. LUNAR trial was including enrolling patients with metastatic non-small cell lung cancer who received at least one prior line of platinum-based chemotherapy. And they were randomized one-to-one between TTF, which is tumor treating field therapy, and standard of care, or standard of care alone. And as you can see, the standard of care is investigator choice between checkpoint inhibitor and or docetaxel. So investigator choice. We will see if it's a free choice or not. The next slide, I think this is one of the main limitations of this trial. What you can see, and this is from table 1, 68% of all patients did not receive previous immune checkpoint inhibitor. And as you may know, since years, the first-line treatment of patients with metastatic lung cancer without actionable mutation is first-line checkpoint inhibitor. So more than 2/3 is not at all reflecting your practice. But the second thing, okay, people are enrolled in, patients are enrolled in this trial, but they can receive, if they did not receive immunotherapy, there is this investigator choice with either checkpoint inhibitor or docetaxel. But the problem here is that it was based on drug availability. And as you know, in some countries, checkpoint inhibitors are not available or were not available. And this is explaining why in patients allocated to docetaxel, 41% of them did not receive a previous checkpoint inhibitor. Again, let's imagine you have a patient did not receive first-line immunotherapy, and then you will randomize this patient to receive docetaxel. You will have received docetaxel, even if if the patient has no contraindication. So the question, how closely does this match my practice? Almost not at all. Now let's speak about the control arm and what should be the control arm. In the Helsinki Declaration, we have major clues. Point 8, research should never take precedence over the rights and interests of individual research subjects. In other words, if you are enrolling a patient and the patient will receive on the control arm a treatment that is inferior to the standard of care, this is taking precedence over the right of the patient. Point 33, and this is not speaking about placebo, which is a specific subject, but new intervention must be tested against those of the best proven intervention. So in other words, it's pretty simple. The control arm should be the best proven intervention. And we will see that there are many ways to penalize the control arm. Some are very direct and straightforward, some are more subtle. This was studied over 6 years of FDA approvals by Talalilal and colleagues, and they found that 17% of approval were based on suboptimal control arms. So this is not rare, and this could be even higher nowadays. There's an ongoing work on that. Let's give an example. First-line ALK-rearranged non-small cell cancer. This trial was showing that alectinib was superior in terms of PFS as compared to crizotinib and led to the approval of alectinib in 2017. And alectinib really became the standard of care at that time. On the right is the Crohn trial. Crohn trial, lorlatinib versus crizotinib. The problem here is that the trial began to accrue in 2017 when alectinib was already the standard of care. And I know that many trialists were frustrated and maybe did not enroll patients in this trial because they feel it was not an appropriate control arm. This was a suboptimal control arm. Now let's see if there are more subtle ways to identify a suboptimal control arm. This is the ASCENT trial, an important trial, sacituzumab govitecan in metastatic triple-negative breast cancer. Patient with at least 2 lines of chemotherapy in advanced disease, patient randomized between sacituzumab govitecan or treatment of physician choice. And the question we have here is this choice a free choice or is it a restricted choice? And we went through this question with Alison Aslam and Vinay Prasad, and we looked at every trial referring to the control arm as a physician's or even investigator choice. And what we find is that this is a pretty recent trend. It started in 2007, and as you can see on the figure, it's really increasing since then. And most of these trials are industry-sponsored, and most are restricted choice. Okay, but let's think about it. Is it really a problem if it's a restricted choice, if you have many choices? Let's see. For instance, in the ASCENT trial, you had 4 choices: eribulin, vinorelbine, capecitabine, gemcitabine, and these were heavily pretreated patients, more than 2 lines of chemotherapy. So what's the problem here? The problem is that you had 2 important options that were not allowed. Platinum-based chemotherapy, 31% of patients were not treated before entering the trial, and we know that it's an important option in these patients. On tricycline, 17% untreated. Again, there could be, some contraindication, but 17% is a significant number, and this was not allowed. So you can see that this is a way that the restriction can prevent important options from the control arm. Another thing to look at is dose reduction and supportive care rules recommendation. We stay in the same trial and take the example of the first occurrence of grade 4 neutropenia lasting for 7 days or grade 3 febrile neutropenia. If you were in the new treatment, sacituzumab govitecan, and you had this toxicity, for the next cycle, no dose reduction and mandatory GCSF. So it's really, higher dose intensity. It's really pushing to higher dose intensity. If you were in the control arm, remember the 4 choice of chemotherapy, then you immediately receive a dose reduction for the next cycle, and GCSF was per physician discretion. So you can see that the dose intensity can be lower. And actually what is very interesting is that in the FDA labels, they mandated for sacituzumab govitecan a first dose reduction, meaning that patients in real world won't be really treated with the same dose intensity than in the trial. And you can check our paper. We made other points about this trial. Another very good example is the REFLECT trial. The REFLECT trial, hepatocellular carcinoma, and this was a non-inferiority randomized clinical trial. Lenvatinib, the new drug, versus sorafenib, the old drug, the comparator. And in patients receiving 12 milligrams, you can see that if they had some kind of toxicity in both arms, there are rules. In the new treatment, if you have this toxicity, you should reduce the dose to 67%. In the other arm, you will immediately be cut in half the dose, 50%. So you can see that there is an imbalance here. The other imbalance is that you can go until 3 steps before stopping in lenvatinib. In sorafenib, after the second step, you will have to stop sorafenib. So there is really rules favoring lenvatinib. This trial is really a proof of concept in a sense because we know that there were similar rates of dose reduction in both arms, 37, 38%. However, they we also know the cumulative dose, which is the dose received by patient as compared to the initially planned dose. And this was higher in the lenvatinib group as compared to sorafenib, and this could have been due to those rules. Again, I showed you 2 examples of these, but maybe it's not so frequent. Can we check that? We did that with, again, Alison Aslam and Vinay Prasad, and we went through 13 years of FDA approvals. And basically, we compared every trial where such comparison could be made. What we found was really sobering. And honestly, we didn't expect such finding. 55% of trials, the rules were favoring the experimental arm, when it was only in 10% of trials that the rules were favoring the control arm. In the other one, it was neutral. And our conclusion about that is what it is impossible to know in all these cases whether the new drug is truly better than the old one, or if better outcomes were achieved by higher dose intensity. So really, imbalance in dose reduction and supportive care rules, you should check this. Usually it's in the appendix, in the protocol, it's not always shown, but I think it's an important point to look at. The last point about the control arm is the duration of treatment. A Bayesian approach here means that to look at all the trials in the same setting and try to look at the duration of treatment when the drug was first tested as an experimental drug as compared when it was later used as a comparator. This was led by Alison Aslam, and if you think about it, the duration of treatment should logically improve over time. Why? Because you have more experience, better toxicity management, improvement in supportive care. And again, if we take the example of hepatocellular carcinoma, we have the 3 trials in green, the sharp one, sorafenib versus placebo, more than 5 months duration of sorafenib. Later, when it was tested as a control arm, lenvatinib versus sorafenib, then you can see on the red line, it's already shorter. And even later in the IMbrave 150 trial, atezolizumab versus sorafenib, it's even shorter. So there may be incentive, maybe unconscious incentive not to push the control drug as much as the experimental drug. And we found that it was present in almost 50% of instances when we looked at many approved drugs. So really, suboptimal control arm, I think, is this slide. You are comparing a new intervention against something which is not your practice, and you really cannot correct after the fact. It's like in this slide, the winner win, but you can't know if the winner really win because he was better or just because he had an advantage right at the initiation of the course. So what to look at in the control arm? This is a summary. Endpoints: progression-free survival, meaningful or simply measurable. This is a great commentary. I encourage you to look at it. And as you can see, there were other commentary, and it's not a new debate. It's a long and ongoing debate, and as you will see, to me, it's not really a debate. But I think one way to think about it is really to understand what is PFS. PFS is a time to event composite endpoint. As you can see in this visual, every line is one patient. Every line is a patient journey. And when you have a step, this means that there is an event happening. So these steps on the Kaplan-Meier curve are events. The fact that it's a composite endpoint means that the event can be many things. It can be death, but it can also be progression in the PFS endpoint. And the last thing to mention, and this will be important after when we will be talking about informative censoring. Censoring can happen because of different reasons. Censoring can happen, you are on the trial, you are doing fine, but the trial is ending, there's a data analysis, then you will be censored. But another reason to be censored is when you withdrawn or when you are loss of follow-up, when you stop the drug before doing the CT scan. And then because you can't assess the event, you will be censored. In other words, time of censoring is the time after which the event cannot be captured, regardless of the reason. And bear this in mind for later. Composite, as we said, and this is adapted from Tito Fojo and Vinay Prasad, and Vinay is really explaining this thoroughly and very elegantly in other videos, and I encourage you to look at them. But basically, you can have either death, either new CT scanner lesion, either progression according to a certain threshold, or respondent progression. So it's really a composite endpoint, not only one measurement. Correlation with survival. This is a very nice paper led by Alison Aslam, and the short answer is mostly poor correlation. At least low or medium, and very rarely high. Correlation with quality of life, and here is a paper from Wang and Gawali, a nice paper, and the short answer again is very poor correlation. They conclude that the PFS benefit was not strongly correlated with improvement in patient quality of life, and you can read the sentence. DFS is the disease-free survival, is the PFS of the neoadjuvant settings. And again, I think it's fair to say that it's not a new debate. I encourage you to check this recent viewpoint from our regulators in Switzerland, Swissmedic. It's a really nice perspective when they try to defend the role of overall survival as a regulatory endpoint in this space. This is the recent approved drug in the neoadjuvant and adjuvant setting by the FDA, and what you can see that every trial, the primary endpoint are DFS-like endpoints. But overall survival was improved in only 2 of them, and at least in one of these, the ADORA trial, there are issues with post-progression, post-recurrence treatment that also question this overall survival benefit. But we won't go into this topic today. So my takeaway messages are that overall survival is a direct clinical endpoint. Overall survival, either you are alive or either you are not alive. But PFS is not a direct clinical endpoint. The poor correlation with overall survival and poor correlation with quality of life. DFS is not a direct clinical endpoint. It's the same, it's a composite time to event endpoint. And what you will be hearing, and many debates about that, should a DFS benefit consider relevant on its own? I think it should really be decided with and by patients themselves. After really talking about what is the endpoint, what is a part of survival, and the part of survival may be and is often, minimal in the proportion of events occurring, and so patient may, value their time without treatment. So I think it's really important to explain those things before taking decisions. And also, and this is the next topic, PFS and DFS are prone to informative censoring. So informative censoring, this is a technical, but I think very, very important thing to understand. Imagine in one arm of a trial, you have much higher rates of censoring. Again, censoring can happen due to many reasons, but it can happen because of patient withdrawing, starting to stop the trial, and this is likely to happen because of toxicity. And a very likely assumption is the patient that will stop because of toxicity are frailer as compared to the patient that will be staying in the trial. And because of that assumption, another very likely assumption is that those patients that are censored were more likely to present the event as compared to the patients that are staying in the trial. And you can see that you can really skew your results if you have an imbalance in censoring between arms. This was very elegantly shown in the Bolero 2 trial, everolimus plus exemestane versus exemestane, PFS benefit but no overall survival benefit. And Usama Bilal and Vinay Prasad, they reconstructed the Kaplan-Meier curves and made different assumptions. There were much higher rates of censoring in the new combination treatment. And what they did is they assumed that those patients that were censored presented the event right after being censored. When you make this kind of assumption and other assumption, best case scenario, worst case scenario, you can see that the benefit can totally evaporate. Another example, informative censoring can affect DFS also. In the Monarch-E trial, adjuvant abemaciclib breast cancer, this is a very nice paper from Meyerson and colleagues, and they show also by taking into account this possibility of informative censoring that the benefit could also evaporate when you make different assumptions. A less known issue with informative censoring is how it can affect overall survival results. And here I will show you the VISION trial. The VISION trial, prostate cancer, many limitations. You can go and check our paper. But I want you to focus here in this. Patient allocated to the control arm, 56% of them initially dropped out due to patient and physician disappointment. The control arm was so limited, was so suboptimal, that patient or the physician decided to withdraw from the trial. After they did some, they call that try and investigate measures, or I don't know, there was still high attrition at 16.3%. And you can think about it, it's very likely that the patient that will withdraw are not the same patient that will be staying in the trial. Patient that will be staying in the trial may have less option to decline, may be less connected, and this is why patient disappointment and such high rate of censoring really undoes the principle of randomization. Last but not the least, informative censoring can also affect quality of life. This is a Checkmate 067 trial, EP-NIVO, NIVO-EP, and we know that the grade 3-4 toxicity are much higher in the NIVO-EP group as compared, for example, to nivolumab alone. This is a 5-year analysis. There were an update after that, but we based our work on this paper. In this paper, it is shown that there is no difference in quality of life between NIVO-EP and NIVO. So again, a huge difference in rate of grade 3-4 toxicity, but no difference in quality of life. And we know that the toxicity from checkpoint inhibitor can be long-lasting, can be, leading of weeks or sometimes even longer of treatment with corticosteroids. So we know that. So this was not reflecting my practice. But what you can see, and this is the number of patients completing the quality of life questionnaire, there is a early, significant and sustained reduction in the number of patients completing their questionnaire in the NIVO-EP arm as compared to the other groups. And let's imagine why you would not complete the questionnaire. And the likely explanation is because you are suffering from toxicity. And this is why missing data can be informative here. When we did imputation data analysis that I think they should have done in the trial, but they did not run such analysis, and we made best case scenario assumption, worst case scenario assumption, assuming that patients that did not complete the questionnaire were suffering from toxicity, for instance. That is a very likely assumption, and we found that the negative impact on quality of life in the EP-NIVO arm may have been underestimated or even cancelled out by informative censoring. So basically, informative censoring, you should really be aware and try to check this in papers, maybe by looking at the number of patients censored, but this is a very important point. Crossover and post-progression, we are nearing the end of the presentation. It's very, very important also, and here you have a very simple explanation of what is crossover. Crossover usually in oncology is unidirectional crossover, and basically it's patient in the control arm receiving the experimental arm upon progression. And here is a very, very nice paper, one of my favorite paper, published in 2018, when is crossover desirable in cancer drug trials and where it is problematic. A first example where it's desirable. when you have a drug that is already proven beneficial in a later line of treatment. For instance, lung cancer, you know that checkpoint inhibitor is already approved as a second-line therapy. If you are moving the line as a first-line therapy, then the patient in the control arm should receive checkpoint inhibitors upon progression. If they are not receiving it because they are enrolled in countries with a limited availability, for instance, your results won't be reflecting what you are doing in your practice. Two examples, the Latitude trial suffered from this kind of problem with only a limited access to abiraterone at progression that was already known to be beneficial, and an example of a trial that had optimal post-progression therapy with a profile 10-14 trial where most patients received TKI upon progression. Another way of a bad use of crossover, we can say a problematic use of crossover, is when the patient will receive, after being allocated to the control arm, the experimental therapy which has no proven efficacy yet. And here the problem is, you see, the time to the next therapy will be longer. And if the experimental drug is not beneficial, you will just delay the access to potentially life-saving therapy. And this most probably happened with sipuleucel in prostate cancer, and you can see a nice paper from Vinay Prasad on this topic. A third way when suboptimal post-progression therapy can affect overall survival is more complex, and I think it's a very interesting point. You can see here in the upper panel, panel A, that if you have many lines of treatment and you have a first PFS benefit, for instance, then this benefit, if you have an optimal access to subsequent treatment, will be diluted by subsequent treatment. And in a sense, this is not bad. I mean, if you are favoring an overall survival benefit, you don't have an overall survival benefit. This is meaning that you can, optimize the sequence of treatment. But in the panel B, where you have a limited access in both arms to post-progression treatment, then the benefit you see in the first line will be more likely to translate into an overall survival benefit, and this is illustrated here. This is from a paper we did recently. And what we did is first I will give this example. This likely happened in the Mona Lisa 7 trial, premenopausal, advanced cancer, receptor hormone positive, mostly in the first line, ribociclib plus hormonotherapy, placebo hormonotherapy. And here the problem is that almost 30% of patients did not receive any treatment upon progression. And in the real life setting, up to 92% after first line hormonotherapy patients received subsequent therapy. And this is also illustrated here. Very often many lines of therapy in this setting. So we looked at every of these aspects through 3 years of approval, and basically the question is how the control arm can be penalized down the road, and this is really the question with post-progression access and crossover. And what we found with this example and this rule, we applied those rules that only 12% of FDA approvals over 3 years had available data assessed as optimal, so it's really, really low. The last topic I want to address is efficacy effectiveness gap. And this is a question about if the results of the trial are applying to the patient you are counseling or seeing. This was a this was a study conducted in Canada, and what they find is that 38% of patients in real life were not eligible for a randomized clinical trial. A good example is the SHARP trial, first-line advanced hepatocellular carcinoma, and in this trial, sorafenib was compared to placebo. Sorafenib provided 11 months median survival and placebo 8 months survival median. Remember, 8 months median survival. in the real life, the median survival was close to 4 months. So half the survival of the placebo in the trial. So this is really an impressive example of this gap, and the fact that the patient we are seeing are maybe in some cases, or maybe often, not deriving the benefit we are seeing in the trials. So how I read, what to look at, I think we covered many topics. We could go through other topics, of course, and this can be done in other videos. But I think one question in how closely does this match my practice? And I will conclude with this slide of how I integrate it. Firstly, the shared decision making. When you have a decision to make with your patients, you need time to read, need time with patients. You should explain the data. It's very important to explain the endpoints. Visuals may help also. An important point to me is don't reject the data. I think it's really important to think about what to make of it and not reject it instantly. It's not really the viewpoint of the regulator here that I'm speaking about. It's really when you have new data, what you will make of it, how you will explain them, what you will be doing with your patients. Involve patients and their relative, of course. Professional activities, research projects, letter to the editor, not too much, question mark. Letters to the editor are also honestly great opportunities to take a deep dive in a paper, but they should not be the only way to read papers, of course. Social media, I put not too much, but honestly, social media is a very good way to follow people that that are appraising the data in a way that you like, and you can have their insights. If it's used in the right way, I think it can be very helpful, giving talks, conferences, and very importantly, teaching activity. I think it should be taught very early on in medical practice, medical education, the importance of the evidence-based medicine approach and the importance of critical appraisal, of course. I want to thank you for your attention. I want to thank the patients, their family, their relatives. They are really at the core of what we are doing. The colleagues and my friends from Geneva University Hospital, the Geneva Swiss Ethics Committee that I joined this year, and it's really fascinating to be in this ethics committee and trying to do better for patients. And I want to thank 3 very important persons here. On the left, Professor Alfredo Adeo, my current boss in Geneva University Hospital, thoracic oncology expert, evidence-based doctor, very supportive of this kind of approach, and it's really enjoyable to work here. Vinay Prasad, of course, which I joined for 1 year in UCSF, and he was very transformative in my way of thinking of oncology, and it's really a pleasure to work with Vinay, and we have still a lot of projects ongoing. And Alison Aslam, of course, part of the team, fantastic researcher. We did a lot of projects, and we have a lot of projects ongoing. And you can check the VK Prasad Lab website. You can also follow me on Twitter. And last word, there is a project that tries to incorporate many of these aspects into a framework. The project is called Theorem with 2M at the end, so you can check that. And as a tribute and to thank Vinay for all this, I will end with the same words as you are ending your podcast, on that positive note. See you next time.